And you know that the pacing-induced cardiomyopathies it concerns after right ventricular pacemaker implantations. And left bundle branch area pacing is currently an emerging trend. And what are the key steps involved in performing left ventricular area pacing, and how can we produce steps for left bundle branch area pacing optimized? So the first of all, I would like to introduce about pacing-induced cardiomyopathy. So as you know, when the patient do the right ventricular apical pacing, it can lead to deleterious effect of right ventricular pacing, and it can lead to the electrical dysynchronized, mechanical dysynchronized, and can lead to the left ventricular structure, electrical remodeling, and also left atrial structure, electrical modal stress, and increase left atrial stress and left atrial fibrosis. And it can lead to the heart failure and also lead to the atrial fibrillation, thromboembolism, and to the next stage is the death. And so we have three causes of abnormal conduction-induced cardiomyopathies. The first of all is the right ventricular pacing. The next is left bundle branch pacing, and the third is pre-excitation. And with pre-cause can lead to the dysynchronized inside, intra the ventriculars, and also lead to the decrease of left ventricular ejection fractions. And as you know that with pre-causing, we can, in the first one, the right ventricular pacing, we can reduce the right ventricular pacing by flip to the biventricular pacing or conducting system pacing. For example, his bundle pacing or left bundle branch area pacing. And the next, we also use biventricular pacing or conducting system pacing. And the third, we can use atrial ablation, radio frequency ablation. And with this therapy, we can improve the ejection fraction of the heart. And where the position of the left bundle branch area pacing, as you see in the picture, here the first one is his bundle branch pacing, and the next is left bundle branch pacing, and here is a left bundle fascicular pacing, and here's left anterior facial pacing. And in the picture, we can see that now we can concentrate to the left bundle branch area pacing. It's modern and it's more effective compared to the his bundle pacing. And left bundle branch area pacing, it consists of left bundle branch pacing, left fascicular pacing, left ventricular system septum pacing will define the left bundle branch area pacing. And here's the study that compares about his bundle pacing and right ventricular pacing. And as you see in the figure, in the patient with his bundle branch pacing, it can increase the ejection fractions. And with the right ventricular pacing, it's decreased the ejection fractions over the time. And so in the patient with the ventricular pacing, about 40% is will reduce the left ventricular ejection fractions. And here we also have two main guidelines about left bundle branch area pacing. The first is European Society of Cardiology and Asia Pacific Heart Rhythm Society, and the second is the Heart Rhythm Society will have the recommendations about left bundle branch area pacing. And in the guidelines said that the intervention with cardiac implantable electronic device who developed reduced left ventricular function or worsened heart failure due to the prolonged right ventricular pacing, CRT cardiac resynchronous therapy is recommended to improve left ventricular function and also heart failure symptoms. And in the patient with a cardiac implantable electronic device, we can upgrade to the conducting system pacing. For example, his bundle pacing or left bundle branch pacing may will help improve the left ventricular function and heart failure symptoms. And here the indication is a lot of the indication in the guidelines about using the pacemaker. And you see that left bundle branch area pacing is present almost the place in the guidelines. It says that the left ventricular branch area pacing has an important role in the patient with the indication of pacemaker. And about the left bundle branch area pacing, I would like to concentrate to the step of the technique to do the left ventricular bundle branch area pacing. So the first step is the preparation. The next is the technical step, and the third is the finishing of the step. About the preparation, we can see that we can have the full system. It's idea that we have an electrophysiology system, but in some situation, in some hospital that we didn't have the AP system, so we can do the left bundle branch area pacing without the electrophysiology system. And it's the ideal system that has the analyzer, AP system monitor, and some instrument for doing the left bundle branch area pacing. And the first step is very important that we have to have a good preparation of the patient. We have to do the echocardiography first to evaluate the thickness of the ventricular system. Here we can see the left bundle branch pacing slit and also the depth of the left interventricular system. And we can also do the same time ECM and ECG at the same time, because with the ECM we can easy to identify that the lead is go deep enough or not. And we also have the 12 lead EKGs. And here the system doesn't have the electrophysical system. Here the programmer. If every branch had the programmer, and so this patient we have used the programmer inside the procedures, and the modified lead, especially we take care we concentrate about V1 lead, and we can use the hasty attacks to the lead, or we have to some hasty stick for the stable the lead. This to intend that we didn't use a lot of the metal because inside the fluoroscopy is can obstruct the X-ray, and so we can give the live transmission of the 12 lead EKGs to the monitor. And here's we print out the monitor. And here the two devices for left ventricular area pacing. The first one is the lead with the stylet. The lead is the common with the Abbott system, and this is common. The lead without stylet is common in the Medtronic system. Here the Biotronic, and here the Abbott, and here the Medtronic. And the second is the procedure step. The first one is that we selecting the pacing seat, and we use the fluoroscopy visualization for the left bundle branch area pacing seat. And here, after we can find out the hits in the position with the electrophysiology system, and here is the tip, is the apex, at the heart. And so the left bundle branch area pacing is about approximately 1 to 2 centimeters from this line, from the hip bundle pacing. And in the LAO 30 degrees, we can see the left bundle branch area pacing in this position also. And here the demonstrates about the AV node, about the hip bundle, is the right bundle, the left bundle, anterior and posterior bundle. So it's very, we can adapt and we can find out the right position depend on the length of the hip bundle. It depends on proximal or distal of the hip, and so we can calculate or estimate the position of left bundle branch area pacing. And we have some special situation that we can rely on the marker. For example, in the patient with artificial aortic valve, mechanical aortic valve, we can rely on the marker in the X-ray, and the position of the left area pacing is above the valve of the aortic valve. And also the artificial valve, mechanical valve, we can find out the position is nearly in the right anterior oblique. This position is near the mitral valve. And also with another projection, we can see the position of the left bundle branch area pacing relationship to the valve structure. And if the patient cannot do the hip mapping, or in the patient in the hospital that doesn't have the electrophysiology system, we can perform the septoangiography. So we can use 10 milliliter of contrast medium to inject inside the right ventricular system, and with the right anterior oblique 30 degree, and we can find out the tip, the summit of the tricuspid valve. Is also the position of the hip bundle pacing. Here the tip, here the summit of the tricuspid valve, and also is the hip bundle pacing. And the target is down to 1 to 2 millimeters from the hip position to the apex of the heart. And we are also using the Charlotte EKG to see where the hip pacing, and also the V1 VRS waveform, and we can find out the W wave pattern at the nadir of the QRS in the V1. So it means that it touched the left bundle branch area pacing. And so here the demonstrates that when we choose the right position, it can have the ASIC is a normal ASIC for in the normal patient. Is the normal ASIC is the normal ASIC is from 30 degrees to 60 degrees is the normal. So it's very physical because it's similar to the normal pacing. In the patient with a very high septum, so in the high septum, the depolarization is toward the leg, toward the 90 degree. So when the 90 degrees of the ASIC, we conclude that it's a high septum. For example, it's a positive in the V1 and negative in AVF. In patient with the apex position or low septum, is the depolarization ASIC is upward. So it means that the tip is moved forward a lot. And in the EKG, we see the AVL positive, AVR positive. And here we can find out the position of the lid by divide at 9 parts. So we have the concentration ring, and we separate in the high, the middle, and the base low septum. High septum, middle septum, and low septum. Low septum. And here the anterior, middle, and posterior. And so the position of left aerial, left bundle branch aerial pacing is in the middle, in the center of the 9 part. And here's the tip. So we identify by the fluoroscopy position of the distal. And advance lead 1 to 2 centimeters toward the apex. Look for the R weight above 5 millivolts with current of injuries before deep fixation. And we see the W node in V1. The next step is the list fixation technique. And in the trial, we can see the left bundle pacing potential and also the W weight in V1. It means that it reaches the left bundle branch area pacing. And we can see the premature ventricular capture because it can touch to the septum. So when it touches to the septum, it can call the PVC. And when the PVC has the QR, small Q and large R, it means we should stop, not to speak, not to rotate a lot because it can cause perforation. And we look about the impedance. The impedance in the right ventricular septum is 5 to 600, and to the mid septum is increased about 7 to 800 ohms. And when it's perforation, it can slow down, it can drop down to the 600 ohms. Or we can see the current of injuries. The current of injury is the idea is about 5 millivolts. But when it's the minimal perforation, it can call the small QA, and it's the totally perforation, it can call the QS weight in the COI. It means that it's perforation a lot. Little perforation is the idea. And also the next step is selection, the optimal lead depth. And here we can use the LEO 30 degrees and looks about the position of the tip. So the position of the tip is ideally about 0.5 to 0.8 centimeters. And we can calculate this the tip. And we can calculate by the marker, this right marker of the tip. And the normal is 1.1 centimeter in the begin the end of the tip. And here the algorithm is an algorithm for how to identify left ventricular aerial pacing. We can use the QRS transient to the left ventricular septum pacing to aerial pacing. We can use the V6 R weight peak time, and also use the V1 V6 peak interpeak interval or LVAT, and also the waveform of the V1 to identify is it inside the left ventricular pacing or not. So about the finishing, we use the cutting catheter. Yeah, it depends on the time of the branch. And we use a fluoroscopy to check about the list position is in good position. And here the case of left ventricular aerial pacing case, the patient with the complete aerial ventricular block, and we use the mode VVI, and we use left ventricular aerial pacing. This with the depth of the lid is suitable, and also we check the projection and check about the position. And after the implantation, we check X-ray again for the idea of the lid in here in the septum. And the EKG is good because the positive in D1 and negative in AVF is mean that it has a normal position of the depolarization axis. So I would like to inclusion that the right ventricular pacing can carry a potential risk of introduced pacing-induced cardiomyopathy, particularly in patients with ventricular pacing about 20%. And left ventricular area pacing is increasing because it's adopted in the clinical practice, especially in the cath lab that doesn't have the electrophysiology. We can do the left ventricular area pacing, and we step-by-step optimization of the left bundle branch area pacing is the key factor for the clinical implantation. And left bundle branch area pacing can perform in unit with or without the EP system. Thank you very much for your attention.